This is how I think things will shake up in the future. Number one is that we need to know exactly what kind of chemotherapy to reduce the burden of disease so that when we use a bispecific, we're not compromising their ability to work. For instance, you don't want to give chemotherapies that would eliminate the T cell population in a patient, like purine nucleoside analogs. That's crazy because you need someone's own T cells to work. And so once we figure out what chemotherapies we can use to actually reduce the burden of the disease, so that's what you do before you do the treatment. You reduce the burden of disease as much as you can and then use this drug. And that's the best chance of number one, a tolerable infusion and also a beneficial infusion. And so I think that both will be used together. And I think for patients that have so-called minimal residual disease or very little disease, or after transplant have the first evidence of relapse, that these will be much preferable to chemotherapy because, especially in patients that are heavily pretreated, they can't tolerate more chemotherapy. Or after you're transplanted, you can't really tolerate chemotherapy very well. And we know also in the patients that relapse after transplant that their outcomes are just dismal. And so anything that's above 5% long-term survival after a relapse after transplant would be beneficial, especially if you don't have to give someone chemotherapy or radiation again.